different subspecialty areas of neuroimaging, subarachnoid hemorrhage, status epilepticus, and stroke. She is on the editorial review board of Neurocritical Care, and she's going to speak to us today about telehealth.
So we're just trying to find my presentation here. Thank you so much for the introduction. So today I'll be discussing a little bit of a different topic than I've talked about at this conference before, but some of the a little bit of research and so forth that I've done in telehealth, and perhaps some things we can learn from it. And honestly, some of these projects are kind of a labor of love for me. No disclosures for this talk. So, it comes as no surprise to all of us that telehealth entails use of telecommunications and additional technologies for various purposes, many clinical, especially as we've seen exemplified in the face of the pandemic. It can also furthermore make care more affordable, potentially more accessible for people, given potential provider shortages in different areas of the country, if geography impedes folks from coming in and seeing, providers directly, and just some, other factors that kind of brought me kind of interested into this field. I did a lot of telestroke consults as a neurocritical care fellow, which were interesting in their own right. And they're mostly a video telestroke, but as I'll discuss partly in this presentation, you can kind of vary the diet a little bit, and I think still come out with some interesting or pertinent information about patients that can enable good patient care. And as probably a lot of we do, some consults at Mount Sinai Morningside, and kind of in a video telestroke type format, specifically and usually for TBI patients there. And as I already mentioned, telemedicine has gotten quite an upsurge due to COVID-19. So, this is me basically during neurocritical care fellowship, hearing the stroke pager go off, which is a ringtone, which I'll probably never, ever forget. And then, us getting onto the, telestroke, getting to the telestroke computer. This is actually a picture of who was my program director during my fellowship, Eric Rosenthal, doing an example there. We were the sending site would send us the CAT scan for us to kind of review the non-contrast, and then upon examining the patient over the camera, as well as viewing the films, of course, would make an assessment, discuss to the providers, and then kind of put in a note here in this system here. And analogously, what we kind of have been doing at Sinai with regards to the Mount Sinai Morningside consults, I guess we've upgraded to cell phones and to kind of a WhatsApp type consult system. And then we kind of get on this teledoc system where you can see the patient actually on your phone, on an app on your phone. And of course, since it's a Sinai site, we have access to the films, of course, and type in our note here and talk to the providers and so forth. So that's kind of how some things have operated in the past and continue to operate. And so today I'll be discussing kind of two kind of main-ish topics. One is kind of how telestroke has been done in one of the health systems in which I've worked with regards to assessment for IV TPA administration, as well as for endovascular therapy. And then the second is a project I did looking at telehealth use in the ICU setting during COVID-19. And so, to nobody's surprise, that as we know, acute ischemic stroke still carries with it, relatively significant morbidity and mortality, which is definitely improved in the last, few decades. The advent of IV TPA in 1995 was certainly an upgrade, and we know, obviously, endovascular therapy as well. But what's not super ideal is a lot of places don't have ready availability to neurologists, or more specifically stroke neurologists, who can provide the level of stroke expertise that can provide on the ground, patient facing care that can allow for, good or, a full detailed assessment that can lead to the administration of any of these therapies. And so this, where I worked at Johns Hopkins prior to this job, they kind of operated with this kind of telephone-based consult system where the stroke neurologist would get a page about a consult in their associated community hospital, Howard County, which is also in the Hopkins system. They'd have, of course, ready access to the CAT scan by virtue of it being a Hopkins affiliate. And they would be basically on the phone with usually the ED doc over there discussing the patient and the patient's examination, including, of course, the anti-stroke scale and relevant factors like that, and any TPA contraindications. And so these next couple of topics I'll be talking about are related to kind of using that sort of model to screen for both IVTPA and endovascular therapy candidacy. So in this particular project, we're aiming to see if this type of telephone-based consult would lead to as safe and efficacious outcomes as doing in-person consults on the ground at Hopkins. So, this last comparison here, this last bullet point refers to the community hospital. Again, this is the spoke, which I'll be here and discussing as the spoke, which uses the telephone-based consult system, as I discussed, and then the academic comprehensive stroke center is basically the hub where you have, on the ground support largely with, neurology trainees who are there all the time, but obviously oversight with attendings. So, a quick comparison of a lot of these patients. This was actually over 2,000 patients in each group that we ended up comparing here over a period of almost 10 years. And so these are all of the folks who received IVTPA ultimately at both the hub and the spoke site. And so kind of a univariate comparison there. And I highlighted kind of the significant values in the rightmost column. In general, people at the spoke who received TPA were a little bit older. There was a bit of a race discrepancy, more African Americans at hub, more Caucasians at spoke, for instance. And there were some discrepancies also with regards to discharge destination, which actually turned out mostly because the community hospital, the spoke, ends up transferring some of their more complex cases, for instance, to the hub site. But overall, the point of this univariate description here was to point out that now, aside from those few differences, by and large, admission anti-stroke scale, discharge anti-stroke scale, and other important factors like, does the patient get intracranial hemorrhage after TPA, were by and large similar between the two sites, regardless of the type of stroke consult utilized, telephone or in person. But, a univariate analysis is only worth, a certain worth, and so we ended up doing some multivariable comparisons as well. This again was a summary slide based on the previous table discussing that, by and large, key metrics were by and large the same. So then in our multivariable analysis, what we ended up demonstrating in the course of this study is that hospital was not an independent predictor of ICH after IVTPA, which we had signified as our primary outcome. So, again, indicative that if you throw a bunch of stuff into a multivariable model that you might conceive might be important in predicting outcomes such as age and door to needle time, and we in some models we also use last known well to TPA time as well. Hospital was not an independent predictor, suggesting that regardless of the type of stroke model that you used, you still ended up with kind of similar outcomes. Other things that came out in the multivariable analysis, which wasn't super surprising, was younger age was associated with the outcome, discharge to home, increasing age with the outcome, deceased at discharge. Interestingly, we did see a little bit of a discrepancy with regards to shorter door to needle times and last known well times to TPA, believe it or not, at the spoke as compared to the hub, which I think is, probably due to some other factors such as maybe access to cars and maybe, knowledge of stroke-like symptoms at the spoke because it's located in a slightly different area in Maryland as compared to the hub site. And then we did also some other comparisons as well to stratify by time, for instance, because as I mentioned, we looked at data over 10 years. So, over that period of time, could metrics have changed a little bit? Stroke care, over time gets better and better. And what could we see there? And, by and large, it seemed like metrics, the twos here signify kind of the second time period. So the second part of the decade we were looking at. It seemed like metrics in general got a little bit better over time in terms of door to needle time and last known well time to TPA, which I guess is encouraging. And that was true for both hub and spoke. So, what we concluded basically from this study is that telephone assessment for IV TPA administration appears to be as safe and efficacious as in-person consults. And, as mentioned, this particular model could potentially reach a wider patient population, leading potentially to more frequent administration of IV TPA. And, if we think about it, on the ground, neurology support and both video telestroke, which is kind of the model I was demonstrating that I did as a fellow, they both come with their incumbent, financial resources that are needed to kind of get those off the ground. And so using a simple telephone call and ready access to an EMR that you already have, access to, could that be more financially feasible and thus could be more, widely used? And so the other thing we kind of sought to show from this is that, yes, similar models have kind of been demonstrated more or less in the literature and kind of looking at what's been done. But ours was the largest by far, 10 years as compared to 4 years in terms of duration of data that we were looking at. And we also, the number of patients we had was the largest outside of a UK study that was done a few years ago too. So some encouraging data there for this type of stroke, acute stroke consult methodology. Then, if we switch gears a little bit to kind of, could this be used to screen for, potential for candidacy for endovascular therapy was kind of another branch of this study. And we're still kind of working on finishing some of this data and hoping to publish it soon. But what we see here is, using kind of the same, data set with kind of the same premise, except for the fact that the community hospital, unlike its ability to administer IV TPA on site, they lack both the personnel and the angiographic suite necessary to perform endovascular therapy. So inevitably, if they're deemed a candidate for this, they would have to necessarily transfer to the hub site to undergo endovascular therapy. So could the same telephone-based system be used potentially as a referral base safely, and allow for potentially similar outcomes between these groups, both the patients who present at the hub and the patients who present at the spoke. And this has been looked at a little bit before this type of kind of referral method, but really it's been done by and large by video telestroke. And so this would kind of be one of the preliminary demonstrations of using this telephone-based only system. So I kind of already mentioned kind of what our basis of comparison was. So, I do have to say that one limitation of our study here is you kind of look at the numbers at the top there, is that in this decade they were looking at, which was about 2008 to 2017, there were not that many patients actually who were sent from the spoke to the hub to undergo endovascular therapy. And, if we think about that time frame as well, we also know that, the signature trials that basically led to more, widening use of endovascular therapy really came out in 2015. So, perhaps by now there'd be additional patients who would be potential candidates for transfer to hub to undergo endovascular therapy. But nonetheless, we demonstrate, at least a univariate analysis, there really wasn't a difference in noted demographics, clinical characteristics, or really outcomes as well, including ICH after endovascular therapy, and discharge NX stroke scale, as well as discharge destination. And then what we also did look at also is, how about those patients who didn't get endovascular therapy? Was there a difference between those folks as well? And in univariate analysis, there was some suggestion that spoke generally, those people who weren't transferred and get it, by and large, were a little bit older, and stroke scale was a little bit higher. There was also a slight difference in race, suggesting maybe more patients could have been transferred, considered for transfer. So, and then, kind of when we're looking at, multivariable analysis, actually, I don't think this is a slide that's looking at that. Oh, I think this is just what I previously described. Looking at the multivariable analysis, referral hospital, again, was not associated with important endpoints. Again, throwing a bunch of stuff into the model and looking at the endpoints that, we had previously looked at with regards to the other study, which, ICH after endovascular therapy, discharge to home, discharge as deceased. Referral hospital is not a predictor, again, further suggesting that, whether the patient came on the ground to the hub and went to the angio suite, or came to the spoke and was transferred and then got endovascular therapy, wasn't a difference. The other notable thing there, actually, that I didn't point out in one of the previous slides, is there's really no significant difference between Doherty needle time and last known well to TPA time, or to endovascular time, rather, which was interesting because this, the patients from the spoke site actually had to, of course, be transferred, and yet there still wasn't a difference in time to getting to the angiographic suite. But in any event, other things that we found in multivariable analysis, that younger age predicted a greater likelihood for discharge to home, and otherwise the multivariable analysis really yielded no other significant results. So again, looking at this telephone-based method that we have, leading to endovascular therapy, appears to be as safe and efficacious as when these assessments are made in person. And so potentially additional hub patients, or spoke patients rather, could be considered for endovascular therapy despite a requirement for transfer, not only because it seems like the door to time of endovascular therapy seems to be about the same, but also because, as we saw, that maybe some of those patients who weren't transferred from the spoke site could be, potentially having higher anti-stroke scale, suggesting there might be, more that could be done for those patients. But of course, as always, other studies are needed to kind of confirm the findings of the previous two kind of topics that I've discussed. So I wasn't sure how we were going to do for time here. So, but anyway, so this is just a quick interlude before the next topics. This is Rio de Janeiro from 2017, back when travel was a little bit more common. So this is just switching gears a little bit to kind of a study I did looking at COVID-19 and telehealth, and more specifically in the ICU setting. And so, it comes to no surprise to all of us, the pandemic has caused many changes in how medical institutions operate, and different policies such as visitor restrictions and reduction of inpatient, in-person, outpatient appointments, and many more that we're all well aware of. And this has inevitably led to changes in how we communicate in the in the healthcare setting. And, we think about the ICU setting in particular, which is, where, I work, trying to communicate with, families and other providers and things like that has been a little bit more of a challenge and has required a little bit of thinking outside the box. And as we know, there's luckily in this day and age, I guess we're fortunate that at the time this pandemic came about, there are many, communication devices now available, many of them with, FaceTime and other sorts of video type access that could permit, fairly good communication. Despite it not being in person. The other thing too that kind of came out of COVID-19 is Medicare and other insurance providers began covering for inpatient telehealth services, including ICU. And I think the last time I checked, I think they still do to a certain degree, though, I think Congress keeps kind of reevaluating whether, and other insurance companies keep reevaluating whether or not they're going to continue to do things like that. And so, I was kind of interested a little bit in this topic based on kind of the prior work I'd done in telehealth. And, to be fair, there had been other studies that had been, looking at the use of telehealth and COVID. But kind of the study I did, which was kind of multiple providers in the US, to my knowledge, is kind of the first survey-based study on the topic of telehealth and the ICU during COVID on at least kind of a national scale. So what we initially did, kind of in its infancy of this project, is to first kind of look just within the health system which I was working at, which was Johns Hopkins, and they have five main hospitals. And so the idea was to kind of survey the ICU leaders at each of those hospitals and kind of get an idea of what they were doing in terms of telecommunications during the pandemic. And then, talking to some of my mentors and other people involved in this project, were like, let's see if we could expand this to other providers. And so we came up with modified the survey, sent one to Neurocritical Care Society, and also sent a similar one to Society of Critical Care Medicine as well, to kind of get as global of a perspective as we can. And the survey was administered from June 2020 to July 2021. It kind of depended when these three surveys in particular were released. And, while the ICU leaders from Johns Hopkins, well, that response rate was pretty good. It would have been nice if the other two response rates would have been a little bit better, but there's only so much you could do, I guess, when you're asking people to donate some of their time to complete a survey. I did try to make it as short as possible, but in any event, and then, one of the first questions I had asked in the survey is, well, how many of you folks are actually, taking care of COVID-19 patients? And by and large, it was a majority of the folks in each of these three groups. And, what was probably not surprising, which was interesting to see on a kind of visual scale, is, were you using telehealth before the pandemic? And, what are you like, what's the percentage that you're using now? And we kind of saw some of those percentages of the previous slide, but an interesting pre-post comparison, I think, can say 1,000 words as well. And all of the surveys, we could see that there was definitely a significant increase in the use post-pandemic. We also looked a little bit at kind of the types of telehealth that were being used, as I mentioned, and which is no surprise to anyone. There's lots of telehealth and different types of communication devices that are used out there. So what are people using by and large? And to cut to the chase at the point of the slide, by and large, we saw that the most common types were virtual meeting software, phone, actually standard telephone without any video communication or video component, and a little bit of FaceTime thrown in there as well. Furthermore, we looked at the types of interactions for which the telehealth was being used for, as well as the reasons that they were used for as well. And so what we discovered is that most of the time, the telehealth was being used to communicate from either the patient to the nurse or the provider to the patient's family. So it was kind of the specific, most common interactions for which it was being used. And most commonly, the reasons that it was being used is either an update on the patient condition or a goals of care discussion. And then I think the third most common reason was consent, to obtain consent for a procedure. So other things that we learned is that, not everything is, hunky-dory when it comes to using telehealth. There are drawbacks. So while it was seen as valuable and taking care of patients by a good majority of patients, and many felt also that after lifting hospital visit restrictions, it may be useful to continue to use some of these telehealth devices. There were a fair number of technical issues that were encountered by people who completed the survey. And then, could there be the potential to create mistrust due to not being able to create in person also came up in the survey as well. So conclusions from this study, we saw that most ICUs cared for COVID-19 patients. Most of the respondents did not utilize telehealth prior to the pandemic, but many did following the start of COVID-19. Generally seen as valuable were these technologies and potentially used for the future. And of course, future studies are needed to confirm the findings that we got. So what are some, to kind of summarize overall this presentation, taking it as kind of a whole, what are the potential future directions that we can take for this? Well, is the first project that I presented was only from one health system, of course, and it would be nice to show some generalizability of kind of that acute stroke methodology that I mentioned, using telephone based consults. One way that we might be able to potentially explore this, for instance, I was thinking is that could we potentially look at the NEMAT database, for instance, which by and large, when we're being called for these cases, we're providing these consults over the phone prior to patient transfer to our hospital, for instance, for subarachnoid hemorrhage and ICH patients. And what do kind of those folks look like versus patients who kind of come into our home emergency rooms? Given the prevalence of, or the need for technologies to communicate with families of patients, maybe there's a better way to kind of assess what might be kind of the better technologies to use and to kind of get a better handle on that. And then, lastly, continue advocating for use of telehealth in medicine. And I know Congress has been kind of carefully considering these, Connect for Health Act, the Telehealth Modernization Act, and perhaps others, and encouraging, insurance companies, et cetera, to continue to reimburse for these technologies. And, there are other issues as well. For instance, lack of broadband access and other sorts of things for, folks who might also have some geographic limitations. So making sure we kind of have an eye on that to make it kind of healthcare for all, and make sure that it's equitable for all. And then there could be potential, obviously, other directions that this, this line of research could take. So thank you so much for your time and attention today, and I'm happy to take any questions.
Sarah, this was great. I have one question, and that's, now that you've been at Sinai for a couple of years, do you see a role in our large health system for telehealth, pre-hospital telehealth consultations in the management of acute neurologic conditions, and specifically with attention to how we triage patients to go to different institutions based on what we think they may or may not have?
I think, we do that sort of, to be honest, to a certain degree. When we hear about some of these ICH patients and SAH patients at other hospitals, I think we kind of do provide some of that guidance in a way, and kind of start thinking about triage in a sort of way of, is this patient potentially beyond the limits of what we can provide from a medical surgical perspective, but also kind of providing some level of advice and support for the providers who are there who may not have that, neurocritical care, neurology, neurosurgery expertise. And so I definitely think that there's, a role for Contigu with that. But like I was saying, it might be interesting to kind of formally, probe that a little bit more and see kind of how we're doing from that perspective, as opposed to, patients who come in directly to emergency rooms and we're kind of, seeing them in person and managing them in person.
So I guess my question is really, can you take it a step further? Like, patient calls their primary care physician because they're feeling off, and then, they maybe give some kind of pre-hospital notification that they're going to a hospital in our health system. Do we direct them somewhere? When they call EMS, can we do some teleconsultation in the ambulance that helps direct them to where to go? Like, do you see any role for that? Do you think it's too non-specific?
You'd have to be a little bit careful with triaging out some of the calls, because you don't want to just hear about someone necessarily who who just has a neuropathy or something, relatively, considered non-benign, I guess, like that. So I mean, I think you could do that. I think that some of the in other healthcare systems, they've been toying with the whole, sending an ambulance for potential stroke codes and being able to do a CAT scan right on the ground, and then through that system they're able to I'm sure a lot of people have heard this already. Consult kind of rate as the patient's in the ambulance, that kind of direct where the patient's going to go. So there's sort of similar ideas that have been in progress, but I think what you're talking about, Peter, specifically, you'd have to kind of, especially within the system that we have now, the ambulance system we have now, we'd kind of have to work on triaging some of those calls a little bit to kind of know, but EMS providers, with the knowledge that they have, the fast scale and things like that, I think it could possibly be doable.
Thanks a lot, Sarah. Can I ask you a question? Are there liability limitations and billing limitations to doing consultations outside the health system? I know you and the NEMAT team will take calls from hospitals unaffiliated with Mount Sinai. Is it possible to bill for that consultation? And is there any medical liability issue?
That's a great question. And I don't know if I'd be the best person to answer that. Like, maybe somebody like, Neha or John or somebody could answer that a little bit better than me. So I don't know about the liability issues specifically. I know for the billing factor, I think some of that has been thought of, but is really not there yet. So as of the time being, there is no billing that occurs for those patients. Oftentimes we will drop a note. For instance, I know, Mount Sinai Queens in particular asks a lot of times for us to, complete NEMAT notes after we kind of perform all these telephone consultations. But yeah, I have to be honest, I don't know the full answer to your great questions.
Okay, thanks a lot. And then Dr. Robert April posted a question. Are you able to see that in the chat? Practical question. My patient calls with urgent symptoms of a possible TIA. What phone number does he call to access a telehealth program? Does he assess over FaceTime? And then how can he coordinate that as the neurologist to go to a Mount Sinai ER?
I mean, I think that would I think necessarily have to go through the acute stroke folks. Because otherwise, I'm not really sure, honestly, how the acute stroke program works here, but normally all of the calls that we typically get though are from EDs from other hospitals. So I'm not necessarily sure there's something set up for doing what he's describing. Honestly, it sounds more along the lines of almost what Peter was asking to some degree.
I see John Liang posted just call 911. I think that is the correct answer, actually. Have them call 911, or you call 911 and instruct them to go to that address if they're unable to call. I have been in this situation with patients who have called me, and I have stayed on the phone with them and tried to direct EMS to come to a Mount Sinai hospital. But if a Mount Sinai hospital is outside the range of where they can go, they have to go to the nearest accredited hospital. So sometimes it's
Makes
challenging
sense.
to direct them.
Makes sense.
All right. Well, thank you so much to all the presenters today. And